Hello, everyone. Welcome back. This is the You Had Me Eat podcast. I'm Erica.
I'm Jules.
And we have a very, very special episode for you today because we have a very special guest. And that special guest has seen the inside of Jules's colon.
Ta-da! We're not sure if he's seen the outside of my colon yet because he's going to see me today in clothes. But
yeah,
yes.
It's going to be weird. It's going to be weird.
He's not going to recognize me.
Mm-hmm. He's not going to know.
Who is this one?
So today we are talking to Dr. Eric Goldberg, and we'll introduce him later. I just want to give you a little preface to who you're about to hear. We're very excited to bring Jules' own GI into the conversation. So please have a great listen, and thank you for listening to You Had Me Eat.
Welcome, everybody, to another episode of You Had Me at Eat. We are honored today to be joined by Dr. Eric Goldberg, who is Associate Professor of Medicine and Clinical Director of Gastroenterology and Associate Chief of Gastroenterology at the University of Maryland. He's also my personal physician, so I'm happy to see you here today on the podcast. Thanks for joining us, Dr. Goldberg.
Thank you for having me.
And Jules is fully clothed, which is probably very different than what you see her.
Do you recognize me, Dr. Goldberg?
I do have a running joke. Sometimes I say turn around, but for this one I won't.
Oh, thanks.
I already did.
Thanks a lot. Yeah.
That's so good. GI jokes. Yeah. GI jokes are honestly the best jokes. So we fully appreciate those here on the podcast. So thank you so much for that.
Yeah, and Dr. Goldberg, you don't know Erica, but she has a big history of GI jokes, so you probably are going to hear a lot of them today. Her poop emoji is like her favorite thing, and I think you have a poop little puff thing in the background, don't you?
I have so many. I've been to so many DDWs and collected all the poop swag. So
yeah.
Well, I definitely need to arm myself with some more GI jokes. So the more, the merrier.
Yeah.
Good.
All right. Well, Erica will give you some today. So.
On a Bristol stool chart, in my heart, you'll always be number one.
Oh, that's terrific.
Wait, get a pen. Start writing these down. Yeah, I think they make bumper stickers of those, don't they, Erica? Didn't you collect a few of those at the last DDW, or was that
they do
ACG? Yeah. Anyway, yeah. So, okay. Well, we wanted to have you on today to talk all things colons. So, are you ready, Doctor?
I am ready.
Okay.
Armed and ready.
Armed and ready.
Well, first, do we want to talk about how you had multiple colonoscopies, but what were your issues that prompted you to even see a GI and that prompted Dr. Goldberg to actually have you undergo a colonoscopy?
Okay, so we're talking about me personally. I believe that Dr. Goldberg answered the SOS call from Dr. Fasano many, many years ago, which is how I first met you, Dr. Goldberg. I don't even remember when that was, but Dr. Fasano is another wonderful friend of mine, and I have had many GI problems after my diagnosis with celiac disease, because as we know, just because you have celiac disease and your celiac is under control, that does not mean that you cannot have a cascade of other problems, especially if your celiac disease was not diagnosed early and your body is riddled with other problems. So Dr. Fasano called his good friend, Dr. Goldberg, and said, please get my friend Jules in to see her, to see the insides of her body. Like, please tell us what's going on. That was many years ago. And he's performed, I don't even remember how many colonoscopies you've performed on me since then, but most recently, just a few weeks ago, because I've had continuing issues with colitis. And that has been just something that I've had for many, many years since after my diagnosis with celiac disease, just ups and downs of colitis. Is that something that you see a lot with people who have celiac disease? You see a lot of commingling of problems with celiac and colitis, or celiac and other IBD issues?
Most definitely. One of the issues with celiac disease is that celiac disease is an autoimmune disorder. So what that basically means is that your body's immune system attacks itself. And autoimmune diseases tend to run together. In the cases of celiac disease, it's very common to have thyroid disease, for example. So Hashimoto's thyroiditis, Graves' disease, those are common coexisting conditions. You can get inflammatory bowel disease associated with celiac disease. You can get microscopic colitis, which is, in Jules's case, one of her issues is that 5% of people with celiac disease will get an inflammatory condition of the colon, where the it behaves like Crohn's disease or sometimes ulcerative colitis, but when you scope the patients, you don't see much. But when you take microscopic biopsies, you see inflammation and sometimes a scarring layer called collagenous colitis. But that is a very common association. Diabetes is another autoimmune condition that's associated with celiac disease. And people who have autoimmune problems, a lot of these tend to cluster. And we do see a lot of coexisting problems in patients with celiac disease.
Yeah, so I think a lot of people who have celiac, they think, okay, well, now I've been diagnosed with celiac, I'm on a gluten-free diet, I'm home free. And that's not necessarily the case. So it's nice to have a little bit more background on that. Dr. Goldberg, thank you for that.
So what were the red flags that Jules presented that is like, it's time for a colonoscopy, instead of just being like, oh, it's IBS, instead of a diagnosis of exclusion or whatever people are calling things now? What are those red flag symptoms that are like, hey, we should probably get you scoped?
Okay, so first of all, a pitch for colonoscopy in general. So we do lots of colonoscopies in gastroenterology, and that's because colon cancer is a very common problem. So it's recommended right now that if you have no family history and you're at average risk for colon cancer, everybody starts screening at the age of 45. Things that, if you have a family history of colon cancer, first degree relative, we start at age 40 or 10 years before that date of the first degree relative who had colon cancer. And in some cases, we see very strong clusters of colon cancer within a family, and we may start even sooner because there are colon cancer syndromes that put you at risk at much younger ages. But in terms of colonoscopy and when should you do it for certain GI symptoms, it depends, but a lot of the things that make us worried are ongoing chronic diarrhea, ongoing abdominal pain, blood in your stool, black stool, which is a sign of old blood in your stool, malabsorption, weight loss. These are the common things that we look for in patients who have celiac disease. If somebody goes on a gluten-free diet and their symptoms persist despite a gluten-free diet, it's either a celiac patient who's not responding to a gluten-free diet, which is less common, or it's some type of gluten in the diet that you're not realizing that you're getting. Or it's one of those coexisting disorders like microscopic colitis or Crohn's disease, for example.
And then backing up to your pitch for colonoscopy, which I definitely want to make sure we hit upon on this broadcast, because I think so many people are unaware, especially of the fact that it's now 45, not 50 is the recommended age. But why is it that, to those who are listening, why is it that colonoscopy, something that is, pretty invasive, why is that's the only way that you can really get a good look and make sure that you're covering all the bases, that you've looked and seen that the patient does not have early signs or does not actually have colon cancer?
Because my next question was, what about those people who just want to do something like Cologuard and don't actually want to have a colonoscopy, even though it's not invasive compared to all the other things that we've done? It's invasive for most people that don't have any sort of procedures or surgeries. So what about these people who just want to be like, well, I don't know, can I just poop in a box and mail it somewhere? Why is the actual colonoscopy the best way to see?
Sure. So colonoscopy is the best option, okay, but it's not the only option. And I think that's an important distinction to make. For certain people, it's highly recommended that they get colonoscopy versus a less invasive test like a Cologuard. So a Cologuard test looks for mutations in the stool, and then it looks for blood in the stool as well. So what you have to understand about colon cancer, and is it really an ideal disease to screen for? Because number one, it's a common problem. Number two, there's a long precancerous phase. So what happens with colon cancer is that you go from normal colon, you get some mutations in the cells of that area of your colon, and that will lead to the development of a small adenomatous polyp. And then you get some more mutations in the cells, and it leads to the formation of a more advanced or larger polyp. And then you get more mutations, and it leads to the development of dysplasia, which are advanced precancerous changes in that polyp. And then you get some even more mutations, and it develops into colon cancer. And then finally, you get even more mutations of that, and that can lead to the spread of the colon cancer. That process doesn't occur overnight. That process takes 5 or 10 years.
Mm-hmm.
So the advantage of colonoscopy is that you can detect a precancerous phase at an early stage, and then you can actually remove it and prevent the development of colon cancer. So you're not going to get that type of benefit from Cologuard. That being said, the most important thing when we look for screening for colon cancer is access to the test. If you're not willing to undergo a colonoscopy, colonoscopy is not going to do anything for you.
Right.
If you're willing to undergo a test that doesn't have as good as metrics, but it's still better than nothing, a Cologuard test is a very reasonable test to order. It's indicated for patients who are average risk. So I wouldn't use it in somebody who had blood in their stool. I wouldn't use it in somebody who had symptoms consistent with colon cancer, or I even wouldn't use it in somebody with a family history. But if you had no family history, no symptoms, and you wanted to know what's the likelihood, that I have something brewing in my colon, there's a reasonable sensitivity and specificity for Cologuard for picking that up. All other patients, I recommend colonoscopy. And, the testing has changed over the years. 30 years ago, we used to do sigmoidoscopies. So we used to do those unsedated. Okay. Yeah. We used to do those unsedated.
Remember
Patients
that.
would come in and we put the scope in, this far and look at the left side of their colon, this far. There you go.
Yeah.
And it was very uncomfortable for patients, and it didn't make clinical sense. It would be like an analogy is doing a mammogram on one breast. You're going to miss half the lesions, and a lot of these are right-sided colon lesions. So it actually probably did more to harm colonoscopy screening today than benefit, because a lot of stigma was associated with unsedated colonoscopies. Today, the hardest part of colonoscopy is getting prepped. And once you've cleaned your colon out, you come in, you get an IV, you get sedated. Most facilities that sedate you for colonoscopy are using propofol, although some are using fentanyl and Versed still. But you don't remember much from your colonoscopy. In fact, you wake up a lot of the times feeling better after the colonoscopy than before, because it's a really nice sleep that the anesthesiologists give you. And in reality, it's a pretty easy test to undergo. I've recently had a test myself, and it's a big nothing burger other than the prep. The prep is the hardest part, but I try to convince my patients to do the prep, and I say that there's a lot of evil humors in your colon, and every once in a while, a complete flush of your system is not a bad thing.
It's like witchcraft. Got to get it out.
Yeah, got to get it out. And then you get your colonoscopy and you can start anew. And I do think that, obviously I'm biased because I'm a gastroenterologist, but all the data indicates that the benefits far outweigh the risks of a colonoscopy.
I do want to also talk about, before we get into the prep, which is everyone's favorite part, I do want to talk about there are some risks. So what makes a patient not able to have a colonoscopy? Is there certain like weight or high blood pressure, or what are the things that make someone not able to have a colonoscopy? Or let's talk about the very minuscule risks, because there are some of like intestinal perforation. Like how big is that risk? Is that something we should be concerned about?
Sure, that's a great question. And anytime you're going to undergo any medical procedure, it's a risk-benefit analysis. So what's the benefit? What's the risk? And then you have to weigh that and determine, is this test right for me? And I would say any patient who's going to undergo any surgery or anything, always make sure you understand both sides of that equation. So Colonoscopy is generally very well tolerated. Because we use sedation for the procedure, we have to make sure patients are going to be able to tolerate that. So the biggest things that concern us are cardiovascular issues. So is there underlying heart disease or potential for heart disease? Are there underlying breathing issues, so respiratory issues, or uh, any previous adverse reactions to sedation? Are patients on chronic pain medication where they're going to require increased doses of sedation in order to get them asleep? Those are the things that we weigh. Most patients, even with heart disease and lung disease, can be sedated, although the venue for where we sedate them changes. So if it's a nice healthy patient with no underlying heart disease or lung disease, we can do those in generally outpatient facilities. If it's somebody who's really sick, we like to do those patients in the hospital. Obviously, if someone has active chest pain or active breathing issues, most colonoscopies are elective procedures, and we like to address those issues and get those straightened out first. But even patients with heart disease can get a colonoscopy. We just have to make sure we've dotted the I's and crossed the T's, and they're gonna tolerate the sedation well. In terms of the actual risks from the procedure, there's three things that are worth talking about. Number one, there's a small risk for perforating or poking a hole in the colon. Now, if we identify, most of the time that occurs in the setting of taking off a polyp, but occasionally it occurs because the endoscopist was pushing too hard to get around a bend, and we call those elbow perforations, and it kind of tears the wall a little bit. I think most experienced gastroenterologists, the likelihood that they get an elbow perforation or from pushing too hard, they generally learn how hard to push it. Those are uncommon. Taking off a polyp, it really depends on the size of the polyp. A small polyp has a smaller risk of perforation compared to taking off a larger polyp. And the likelihood overall is quoted about 1 in 1,000 cases. So if you wanted to assess your risk, it's a 99.9% chance you're not going to have a perforation during a colonoscopy. The problem is, if you have a perforation, a lot of the times that's going to require surgery to fix. If your endoscopist is skilled and recognizes a perforation during the procedure, we can clip those up, or we can even have suturing devices that some of us are familiar with. But if you don't recognize it at the time of the perforation, some of the colon contents can spill into the abdominal cavity, cause infection, and it leads to a surgical emergency. And sometimes that requires a temporary colostomy. Again, there's a 99.9% chance that won't happen, but it does happen. It's, if you do enough colonoscopies, even the best colonoscopists will have complication like that. The other risk is bleeding, which again is uncommon if we don't do some type of intervention in the colon. But if I'm doing a big polypectomy, the bleeding risk is about 1%. The good news is that most bleeding stops on its own. Occasionally we have to put the scopes back in to make them stop after taking off a big polyp, but that's not that common. And then the third thing that's definitely worth mentioning is that colonoscopy is not a perfect test. So everyone just assumes that they've had a colonoscopy and they're clean, but even they've done studies where patients get tandem colonoscopies. So one doctor does a colonoscopy and then leaves the room, and another doctor comes in and does the same colonoscopy. And what they find is that lesions get missed, even in expert institutions. Some of these were done by academic physicians. Most of the studies were done in academic centers, and presumably that's where your best colonoscopists are. But even in expert hands, there's a miss rate. So for small polyps less than 5 millimeters, which are probably insignificant polyps anyway, the miss rate is as high as 25%. And then for large polyps or polyps or even cancers, the miss rate is between 1 and 5%. It really makes it important for the endoscopists to take their time when they're doing their colonoscopies. It's not worth it, in my opinion, to rush through a colon. Right. I mean, if you want to get to the end of the colon and then start really looking carefully, I think that's fine, but it's not worth it to kind of pull the scope out fast and bring the next patient in. as a physician, you have to decide what's important for you. And for me, I don't think I could sleep well at night knowing I didn't do my 100% best job for a patient. And so I'm always taking my time during the colonoscopy and really scrutinizing every area, sometimes putting the scope back into areas that I don't feel like I saw well to make sure I'm not missing anything significant. So, and I think most gastroenterologists feel that way, and do a very good job. But again, that's where I think patients need to investigate is, what kind of reputation does your GI doctor have? Is your GI doctor doing 25 colonoscopies a day, or are they doing 6 to 8 a day and really focusing on doing a good job? So I think that's an important thing.
I will say I saw a picture of a polyp for the first time ever, like a small polyp, like something that I've had removed, at an ACG lecture or something. And I'm like, I'm sorry, that's a polyp? It was, I don't know how you catch it. I mean, I know that you're trained on this, but it just looked like everything else. I mean, the tiniest things, like, no, of course there's a miss rate. It doesn't look any different. I just look at these being like, even the larger polyps, I'm just like, oh, that's it. Which I guess is why, GIs are trained so well, because to the naked eye, to the lay person, it doesn't look like much. And again, we don't really look at colons a lot. So
and it also helps during your case to have the nurses looking while we're doing our procedures, and having our techs look, having a fellow or a resident in the room. The more sets of eyes, the easier it is to kind of pick something up. Believe it or not, AI, or artificial intelligence, is making its way into screening colonoscopies, and they have computers now that hook up to your processor, and it will put a circle around a lesion that it thinks is a polyp. And there's a lot of false positives, so it'll put lesions around and say, is that really a polyp? I'm not so sure. But it actually it's beneficial for picking up polyps, and it definitely helps with the miss rate.
That's really cool.
And so one benefit of our robot overlords taking over us is that maybe we can get more polyps detected on colonoscopy. How exciting for us and our robot gods.
And our robot gods.
This question, we've got to ask about the prep, Jules.
Yes, we have to ask about the prep, because a lot of people are so afraid of this prep. But the last couple times that I've gone through it, I've specifically asked for the Miralax prep, which is very much less, I think, traumatic. So could you maybe describe the two? As far as I know, there's two basic prep options.
There's several prep options,
but they're in two camps, basically. Okay, well then tell us all the prep options.
There's so many. We're so confused. It's so confusing, and we just know that it's going to be an uncomfortable night for us. But I think that giving options at least makes us feel a little better. So yeah, hearing the options would be great, and what you honestly think about them.
Yeah, so myself, I've had 3 or 4 colonoscopies. I have some underlying GI issues. Very good.
Welcome to our club.
I am part of the club now. I'm officially part of the club. Not the celiac club, but the inflammatory bowel disease club. So again, autoimmune problems run rampant through my family, and they certainly run rampant through me. But in terms of the prep, one of the most important things is adherence to a liquid diet the entire day before the prep. So where we see problems with poor preps, a lot of the times patients will actually try to eat a solid food, or eat something that they shouldn't be eating, but they think that they can get away with it.
Like you're not going to find out.
But staying on a liquid diet, anything that you can see through is generally fine. Coffee is fine. But doing that the entire day helps to flush your system. Another thing is, certain foods are very good for the colon, like salad, nuts, high fiber foods, but they're not good for your prep. So those are foods that you kind of want to stay away from in the days before your colonoscopy. So I think that's important for kind of clearing that out, because when we do your colonoscopies, we generally can see what you've been eating if it's not fully flushed out. Now, in terms of the
That sounds
prep.
like a lot of fun, by the way.
Oh yeah,
Do
yeah.
you guys just stand around in the
Sometimes you're like,
OR
what is
like,
that? Is that corn? Is that watermelon seeds? That looks a lot like onions. So
oh, that must be just quite the running joke between. All right, $5 says that's like ew.
we see some interesting stuff. Like one time, I thought it was a polyp, and I reached in and I realized it wasn't attached, but we still send it to the lab, and I removed it, and it comes back as like skeletal tissue. And then I'm like, what's skeletal tissue doing in there? It just turns out it's like some type of animal meat. But you'd be interesting what we see in colons.
Oh,
But in terms of
speaking
the
of
actual prep,
witchcraft. Oh, gross. What did this person eat?
yeah, we get used to it. I'm kind of numb to all of that stuff. People always say, "Yeah, how did you become a gastroenterologist?"
Yeah.
With dealing with all this kind of stuff. But when you do medicine, you kind of have to pick your poison. And if you're a cardiologist, you're dealing, with blood, and if you're a trauma surgeon, you're dealing with blood, or if you're an ENT, you're dealing with snot, and if you're a pulmonologist, you're dealing with sputum. So as a GI doctor, we deal with some blood, but we deal with occasional vomitus and stool contents. But most of the patients do a very good job on their prep. So 95%, they come in and their colon is wiped clean and it looks great. So that makes a big difference in terms of the quality of the exam. In terms of the actual prep, volume is important. So if you're going to do Miralax, which it turns out to be somewhere between 13 and 15 scoops of the Miralax, the key is to make sure you're drinking plenty of water and plenty of fluid while you're prepping, just to flush the system, especially if you have things that slow down your system. For example, narcotics or medicines that we call anticholinergic medicines. For example, Benadryl, that will slow the emptying of the colon. Uh, so volume is very important. Because most people don't focus on volume, you have Go Lightly or New Lightly, which are these jugs of fluid that are generally not that palatable.
Nope.
But they have a whole, 4 gallons of it, so that, 4 liters of it, so you can clear yourself out.
Feels like 4 gallons.
But yeah, exactly. But you can do that on your own if you're drinking enough fluid. So the key is to just keep pounding fluid with whatever prep you decide to do. There are options besides Go Lightly, which is polyethylene glycol. In the past, we used one called Fleet's Phosphosoda. They still have Fleet's enemas, but they don't have Fleet's Phosphosoda because the phosphate was damaging people's kidneys, and there were some studies showing that
Bummer.
phosphates could damage kidneys over time. So we got away from some of the electrolyte type preps like Fleet's Phosphosoda, but they're still out there for young, healthy patients. There's even pills that you could take that have different types of laxatives in them. But again, the key is to drink plenty of fluid with the pill preps. The pill preps are generally okay for young people with no hypertension and no kidney disease. But once you get into the 50s and 60s, they generally have some risks that we tend to avoid those pill preps for. But there's definitely some options.
Mm-hmm.
Well, but regardless of the prep, you should be, what should your toilet contents look like when you're ready to go?
Basically, you should be able to see through it. So it can be yellow. It can be like a slight tinge of stool in it, but generally you should be able to see through it. It should be basically resembling what you're drinking.
And here's my question that I always run into. I always feel like I'm going to crap my pants while I'm driving from my home or being driven from my home to the center to get my colonoscopy. Uh, What is a patient supposed to do during that time?
Yeah, that's a tough one. And there's no great answer for that, especially if you have a long commute. We have patients, for example, I'm in Baltimore, and I have patients who come down for big polyp removals from the Eastern Shore, and that's a few-hour drive, and it can be hard. I think we don't want to use anything that's going to slow you down. So we don't want antidiarrheal medicines in that circumstance. And so what, unfortunately, I have to say, kind of grin and bear it, and maybe focus on depends or focus on something to help you kind of stay calm to assist in your continence?
Because Mayo Clinic, where I go, is very far away from where I live. So I'm like a 45-minute drive just clenching the car seats. But that's always been my biggest. I mean, the prep also is horrible. Let's not get it
Yeah.
wrong. But like the drive there, I think is probably the most uncomfortable for me. There has to be some sort of like maybe including a diaper along with the prep. It's like, here, this is for you
Sounds
before
like a
you go to
business model.
colonoscopy.
There you go.
It is. We need to, because honestly, that's one thing that I didn't think about my first time being like, oh God, now that I've gotten rid of everything, how am I supposed to hold it in until the colonoscopy?
It sounds like a great business idea.
Yeah. And so any tips for someone getting their first one for afterwards? Do you want to talk about the running joke about the farts in the post-op?
Is that me or Jules with the fart jokes?
No, Dr. Goldberg, you have to fart before they take you home.
There are so many on TikTok. Like, have you seen them? They're hilarious. Like the TikTok post colonoscopy fart videos are very funny.
Some of those are quite humorous, and I always tell the patients not to worry. Where we do colonoscopies, different facilities use different types of insufflation devices. So when we do a colon, we have to blow the colon up like a balloon so that we can see. So most places use air, which is 21% oxygen, 79% nitrogen, and it doesn't diffuse out of the colon well. So that air, when you pass it, it has to come out as a fart. And some institutions like University of Maryland, we use CO2, and CO2 tends to diffuse away, so you don't get as much air left in the colon as you would with regular air. But I always kind of joke with the patients and their families, and I tell them, doctor's orders, you have a prescription to fart. Get it out, because it is a little uncomfortable. And the good news is that if you're prepped, your farts don't stink. So that's the good news.
That's lovely.
But after the colon, you really shouldn't have any discomfort. You should, other than some bloating and the need to pass some gas, there shouldn't be any pain. The only thing that really hurts in your colon is stretch. So at the end of the colonoscopy, we generally try to suck out as much air as we can to decrease the wall tension and decrease that stretch on the colon. But even biopsies don't hurt inside the colon. There shouldn't be any pain. If there is, it's a red flag sign that maybe something went wrong during the procedure. So we always have our patients call us if they have pain that persists after a colonoscopy.
I wanted to ask a quick question before we let you go, just on some things that patients should be asking their physicians about colonoscopy and endoscopy before they go in, because we've been hitting on the colonoscopy the whole time. That's the lower, but the endoscopy is the upper intestinal tract. And that's where a lot of our listeners will be interested to hear more about that as well, because that's where celiac is diagnosed. But before you go in for an endoscopy and before you go in for a colonoscopy, what should you be asking your physician in terms of the number of biopsies that need to be taken from the upper endoscopy and from the lower, from the colonoscopy, in order to be sure that you're getting the best representation of the picture that's been taken? We've already talked about the fact that things can be missed, obviously, because that's a very large expanse of territory that you're looking at. But, when you're looking for celiac, for example, there's a certain number of biopsies that need to be taken in order statistically to get the best representation of a chance at accurate diagnosis. When you're talking about for a colonoscopy, how many are you looking at taking there for biopsies to get, for something like microscopic colitis or things like that? How many are you taking from what parts of the colon are you looking to make sure that you've actually touched all the bases?
Sure. So from the upper procedure for celiac disease, and again, it depends what we're looking for, and there are quality indicators that gastroenterologists are supposed to follow.
Right.
So when we're looking for celiac, celiac can be patchy, but in general, it tends to affect the most proximal small intestine the worst, and then as it goes down the small intestine, it tends to get a little bit better in terms of the mucosal damage. So more often than not, the mucosal damage is right there in the duodenum, which is the first portion after your stomach. And the recommendations are that we do 6 to 8 biopsies of that area to make sure that we're not getting sampling area, like we're not biopsying an area that just doesn't have the same amount of inflammation as another area. So I think 6 to 8 biopsies is enough. I generally do 6 biopsies in the second portion of the duodenum, and then I pull back into the duodenal bulb and I do 2 additional biopsies there. A biopsy is not a huge thing. It literally takes, to do 2 bites, it takes 10 seconds. Then we take the scope, we take the biopsy forceps out, we put it into a little biopsy container, they hand it back, and that whole process takes 30 seconds. So to take 8 biopsies, literally is a 2 to 3 minute event, and there's no reason not to follow the recommendations of getting 6 to 8 biopsies. Now, if we're looking for H. pylori in the stomach, which is a bacterial infection that affects a lot of people who are going for upper endoscopies, it can cause ulcers, it can cause gastritis, it can even cause stomach cancer. It's recommended that we take at least 2 biopsies from the antrum of the stomach, which is the end of the stomach, and 2 biopsies from the body of the stomach. And so, again, it's not long. I can generally do an upper endoscopy and feel like I'm done a really excellent job visualizing everything in 5 to 10 minutes.
Wow.
A colonoscopy, for me to insert it from the rectum to the top of the colon, takes anywhere between 6 to 12 minutes. And then I generally take 10, 15 minutes pulling the scope out. Studies have shown that, gastroenterologists who spend at least 6 minutes pulling the scope out, they pick up more polyps than gastroenterologists who just pull the scope out with quicker withdrawal times. And then in terms of biopsying for microscopic colitis, in general, I put it all into one jar, and I'll take 2 biopsies from the cecum, 2 biopsies from the ascending colon, 2 biopsies from the transverse colon, 2 biopsies from the descending colon, 2 from the sigmoid, and 2 from the rectum. Some people do less than that, and they'll just do 2 from the right colon, 2 from the transverse colon, and 2 from the left colon. And I think that's reasonable too. I just take a little bit more. Now, if I'm looking for ulcerative colitis, whether or not somebody has dysplasia in their colon that puts them at higher risk for cancer, then I'm doing 4 quadrant biopsies every 10 centimeters in the colon. So it depends on why we're doing the biopsies, what indication, but there are quality indicators that we follow that the studies show, and we teach it to our residents and fellows that are doing these procedures as well, so that they come out doing it the right way. And, I think as long as you're taking your time and trying to follow the guidelines, you're going to get good samples.
I think that's really helpful.
Can I just tell you how lucky you are to have such a cool gastro who's clearly just in your colon and is like, let's check out Jules' colon. That's awesome. I think that's great. It's so interesting to hear because we don't know what's going on when you have a scope inside of our colon. It's really, really cool to hear what actually happens during a colonoscopy. And hopefully when readers are listening to this, they're like, oh, I get it. Now I see why it's so important. And it's not just a torture device to try to hate you aging and hate growing older because you have to have colonoscopies. But I think it's really important to know how vital and critical these tools are to help you maintain good health in your digestive tract as you move forward with aging. But this has been so fascinating.
Well, yeah. And I guess the only last piece that we need to know, you said we should be getting a colonoscopy at the age of 45. How often is the recommendation after that?
So if everything is clean in your colon, every 10 years is enough. And in general, we stop screening at age 75. The new guidelines say that if you have small adenomatous polyps, which are those small precancerous polyps that I was telling you about, probably every 7 to 10 years is fine. So small being less than 10 millimeters. If you have advanced lesions, so something that's bigger than a centimeter, or so it has what we call villus histology or high-grade dysplasia, then we do that every 3 years.
And for celiacs, how often should we be going back for an endoscopy just to check and make sure that all signs are a go? I know we're supposed to go back for the serologies, but how often would you recommend, and what is the current recommendations for actual endoscopy? Because that is a lot more invasive than just going back to have your blood work done.
Yeah, we definitely see that there can be a discordance between the
Yeah.
serology and the
Mhm.
histology.
Mhm.
So the serology is good to have every year,
Mhm.
at least once you've been firmly established and you're under control. If you're having symptoms or you're having issues, that's a different story. But if you're feeling well with celiac, and I think then yearly serology is good. Insurances generally will cover a upper endoscopy every 5 years or so. And I think it's reasonable to reassess every 5 years or so to make sure that there's not inadvertent gluten intake in your diet, and to make sure that you don't have some type of refractory celiac going on. Celiac can do things that you may not be aware of. For
Yeah.
example, you may be not absorbing certain micronutrients well, even though you feel well from a GI standpoint. So if you're not absorbing your vitamin D well, it might put you at risk for osteoporosis down the road. And I think a biopsy could help us understand that your celiac is active or not active.
Right.
Or uh, people with celiac have higher risk for certain types of malignancies in their small intestine, as well as lymphomas, and it depends on the level of activity of the celiac and whether or not there's mucosal inflammation. So again, the serologies are, I think they make us feel good, but there's definitely some discordance, and I think every 5 years would be reasonable in that circumstance.
Perfect. Okay. Thank
I
you.
love it. And obviously, we want to put the caveat here that you should speak with your own GI and make your own medical decisions under the care of your GI, but make sure that you have a good GI, because
Exactly.
honestly, that's the biggest issue that we run into.
Yeah.
And also feeling comfortable enough to ask these questions that we just asked Dr. Eric. Like, what are these questions, to ask? What is the color of my prep supposed to be when I'm done with it? I think knowing your GI and feeling comfortable asking these questions is critically important. Finding the right GI for you may take some time, but once you do, like the relationship that Dr. Goldberg and Jules have, like that's important too. And we shouldn't discount the relationship that you have. Even these visitations might be short and they really don't get to see the front part of you that often. I think it's important to have that good relationship.
Yeah, absolutely. Well, and we thank you very much for your time. We don't want to take more of it, but do appreciate it very much. Appreciate your bedside manner and appreciate you sharing that with all of us today on You Had Me at Eat.
I really
Dr.
enjoyed
Goldberg,
being
thank
here.
you.
Thank you for having me, and anytime you want me to come back, I'm happy to come back.
That would be wonderful. Thank you so much.
All right, thanks, guys.
Okay, bye-bye.